Good morning. I'm Dr. Karen Boretsky, and you can go ahead and read what I have to. Oh, good. You've already read all that. I'm just readjusting the microphone so it's small enough that I can talk into it. And this morning I'm going to talk about local anesthetics in children. My assigned topic was which, why, and how much, and I snuck in where. And we're going to talk about some of the best practices. My passion is regional anesthesia, and you'll discover that. First, I want to say namaste. And I had to look up the word to find out the appropriate use and what was being said to me every time I received a message from the APSA. And it's very appropriate because it's a mutual respect and greeting between teachers and students. And I think that sort of embodies what we're all about, taking care of children, which is in fact God's work. In the United States, we always have to have a disclosure if we work with any particular companies. I do want to say that I do help to make ultrasounds more pediatric friendly, and so I do work with the Analogic company to make ultrasound equipment appropriate for children. And before we talk about local anesthetics, I just want to take a second to set up the premise that children do have pain and that regional anesthesia is quite effective therapy. I'm not going to dwell on that. Dr. Bosenberg will speak about that later in the afternoon, but regional anesthesia is a very, very powerful way to manage pain in children and to keep them happy and safe. I'm proud to say the number of children receiving regional anesthetics has been increasing over the past 10 or 15 years to the point where the published data shows that roughly 20 to 25, almost 30% of children are receiving regional anesthetics. And I think that we as pediatric practitioners should be very proud of that because we have owned regional anesthesia for a long time, starting back with the kitty coddles. And we need to continue to nurture that as an aspect of our specialty. So the overview of the lecture, I want to keep it simple. So it's which local anesthetic, why I choose that local anesthetic, where to put the local anesthetic, and how much. So simple. Now that's simple, but what isn't simple is the implementation of this topic. And I wish that I could just tell you, well, this is the best anesthetic to use, and this is how much you use. But in fact, all the situations are different, and there are a lot of variables. I'm going to try to distill it down, but the most important variables you can see are age, and we all know that neonates act very differently than non-neonates. Children with comorbid diseases, it affects pharmacokinetics. And specific to regional anesthesia is what regional technique have we chosen for our patient? Is it a neuraxial block, a peripheral nerve block? Is it are we looking at the nerve? Are we doing a plane? These single injections or these catheters? And so these are the major variables that you have to think about when you're choosing your local anesthetic. We have a lot of choices out there. This is sort of from the medical school books, the local anesthetic choices. We have our esters. The two most useful are 2-chloroprocaine and tetracaine. Under the amides, we have the bupivacaine, ropivacaine, levo, that's misspelled, levobupivacaine, lidocaine, and mapivacaine. The main difference is these are very different drug groups. They all numb the nerves. But the amides, when you go to choose your local anesthetic, what you're looking for is what's the duration, what's the onset time, what's the toxicity, and what's the elimination. We find with the amides that these are very appropriate for longer acting when we want the block to last a longer time because they have a longer duration. If you're doing it with inpatient surgeons, there is a longer onset time, so you have to be clever and get the block in before the surgeon's ready to start. Unfortunately, the amides do have somewhat increased toxicity, but we'll talk about how to keep that safe. And there is hepatic and renal metabolism. So in patients with those comorbidities or immaturities, we have to be very careful with our amides. For the esters, very short duration, very quick onset of time, and they're not dependent on any major organ systems for elimination, making them very nice drugs for hepatic and renal impaired children. I do want to point out that true allergic reactions to local anesthetics are very, very rare. And if you find a child with an allergic reaction to one class, if they're allergic to a drug in the amides, then there is no cross-reactivity between the two groups, so you can still administer a local anesthetic to a child who's allergic to one group of local anesthetics, knowing with confidence that there is no cross-reactivity and they should be just fine with the other group. One of my favorite groups, I use almost exclusively amide local anesthetics in children older than 6 months of age. I put together this chart to sort of help us decide how to choose and to look at the different safety profiles. There's lidocaine, bupivacaine, levobupivacaine, and ropivacaine. Lidocaine isn't much favored for direct perineural use in children because of the high association with direct neurotoxicity. It's very useful for local infiltration and has a relatively high CNS toxicity and good motor block. The bupivacaine has less direct neurotoxicity, but increasingly, I'm not going to go through all this. You can read this. This is in the souvenir handout. And everything that's in the tables are in the handouts, so you don't have to memorize it. Just try to listen and get the general ideas, and you can look a lot of this information up later. You're going to notice that there are very few pluses. Pluses is a good thing. 3 pluses is bad. 1 plus is good. And increasingly, practices are moving away from bupivacaine towards ropivacaine because the better safety profile in terms of direct neurotoxicity, CNS toxicity, and seizure activities with inadvertent high dosing. The cardiac toxicity is much less. And in fact, in children, when we want to preserve motor function, the motor function is better preserved when you use ropivacaine. The main downside of ropivacaine is that in many countries it's still more expensive than bupivacaine. But if you have the luxury of using ropivacaine, the cardiac toxicity is roughly half of bupivacaine. But if bupivacaine is all you have, just pay attention because I'll give you safe ways to use it, and we'll talk about that. The minimum safe bolus dose, I hope you can read this. I should have bolded it a little bit more. Now, when you go to the textbooks and you read about the maximum safe bolus dose, this is not to be confused with the recommended bolus dose. For each individual block, there will be recommended doses, and you never ever want to start with the maximum dose because you're skirting complications with that. But when the surgeons look at you and say, how much can I give with infiltration? When you're looking at your blocks, and if you have to give multiple blocks, you need to know the numbers for the maximum you can give so that you stay below this number. I don't aspire to this number. This is the cliff. I want to stay away from the cliff. And this is in the handout, so I'm not going to read these numbers to you. I don't want that screen to go black while I'm still standing up here. In terms of the esters, in contrast to the amides, in fact, on one of my previous slides, I said that the esters had a better toxic profile. That is not true in terms of tetracaine. Tetracaine can be very cardiac toxic, and in fact, tetracaine is used only in small, it's used only in small doses. Is he trying to get a hold of me? Okay. It's used only in small doses for spinal anesthetics, and you can certainly use bupivacaine. My favorite ester for patients and it's very useful in patients less than 6 months of age, is 2-chloroprocaine. Now, this ester is degraded by plasma esterases, as are all of the esters. It has a 20 to 30 second plasma half-life. Neonates have decreased cholinesterases and plasma esterases, and in fact, the duration in neonates is only 40 seconds. The main drawback is that it's a 45-minute duration. Speaking of small infants and neonates, this is the one age group where we have to be very careful. The age-specific pharmacokinetics of local anesthetics in this group this is the one age-dependent variable. Patients and this slide will be no surprise, patients less than 6 months of age have decreased liver metabolism, decreased renal excretion, low alpha aminoglycoprotein, low plasma protein, and fortunately a higher volume of distribution, which translates into, on the right-hand side, you can see all of the effects that these physiologic changes have on the pharmacokinetics, and we see that if you use an amide or a drug that is dependent on liver metabolism, renal excretion, and protein binding, you see a tendency for accumulation. So on children less than 6 months of age, and we should be embracing regional anesthesia in the neonates and infants. It's safe. Just remember to dose smaller. So the bolus dose, because of the volume of distribution being higher, the bolus dose really isn't unchanged. It's really the infusions. And this is where I like to use my 2-chloroprocaine because of the safety profile. And I just put this slide back up here because it reinforces that I also put esters up here, and you can see your dosing regimens for esters. In terms of recommended dosing, as in all of pediatric anesthesia, we dose by age and weight, and the weight is expressed as mLs per kilogram when we talk about dosing. This is age-specific, block-specific, whether or not you're using a bolus or a catheter, and it is calculated using lean body weight. Dr. Learman is going to talk about a lot of the changes that chubby kids, adjustments you need to make. And in fact, since you're looking right at the nerves and the neuraxial spaces are similar, you do not have to modify your doses up for kids with obesity. In fact, you do need to just use their lean body weight. In terms of neuraxial regional anesthesia dosing, I put some recommendations in your handout. For caudals, because it's a more open, distendable space, we talk about using 1 ml per kilo. Once you move up to a lumbar epidural, 0.7 mLs per kilo. And because of the confinement within the thoracic canal, 0.5 mLs per kilo is recommended. And the infusions are similarly noted there. When we talk about peripheral nerve blocks, this could be a whole lecture in and of itself, how we decide to dose individual peripheral nerve blocks. This specific compendium is in your handout, but you can break the peripheral nerve blocks down into if you're looking right at the nerve, or whether you have to fill a space with local anesthetic. So for instance, for a femoral nerve block, we will use smaller doses of local anesthetic, 0.2 ml per kilogram, because we're looking right at the nerve, and it's very easy to surround it. If we're doing a paravertebral block or an epidural, you would use perhaps 1/4 of an ml per kilo, and this shows the good spread that we get with 0.25 ml per kilo. A lumbar plexus is a field block and will require 0.5 ml per kilo. One of the major turning points over the past few years has been the use of ultrasound which has allowed us to decrease our dose and make this safer. There's a listing here of continuous infusions for peripheral nerve block catheters based on site of action. And I'm not really going to have time to talk about why we should all be moving away from neuraxial regional anesthesia to peripheral nerve blocks, but increasingly you're going to hear us talk more and more about doing peripheral nerve blocks in children. And I just want to say that meticulous attention needs to be paid to dosing, and that, if they don't black me out, the most important thing you can take home from this lecture is that knowledge and adherence to dosing limits and the use of local anesthetic concentrations and volumes appropriate to the clinical situation probably has a greater impact on risk and safety than the choice of specific local anesthetic. Thank you.